Let's turn now to Dr. Elaine Saayman, who is the leader of clinical services at the Sediba Hope Medical Center in South Africa. Elaine is a physician. Her experience spans across various aspects of HIV and viral hepatitis management and clinical care. She's currently pursuing a Master of Public Health at Johns Hopkins while leading clinical services at her nonprofit organization in South Africa. She does her work in collaboration with colleagues at the University of Cape Town. Elaine, we look forward to learning of your experiences. Thank you.
Thank you so much for the introduction, and thank you for the opportunity to share our work. So today I'll be sharing my experience in integrating hepatitis C services in a community-based setting, particularly amongst people who inject drugs, who comprise about 50% of our homeless population in the nation's capital. So you might be familiar with the global burden of disease, and especially also with the low case finding, even more so on the African continent. So I just quickly want to focus on our context in South Africa. So our local screening efforts have really been limited, also probably due to the level of care where treatment is being offered. And this is especially concerning in people who inject drugs, where we see a very high Hep C prevalence, about 55%. And some of the drivers of Hep C infection includes a high prevalence in both HIV and hepatitis C, with almost 15% HIV co-infection in those with Hep C. We also have high rates of risk-taking behavior in the PWID community, and then really limited access to both prevention and treatment services, which is further underpinned by low referral rates and persistent socioeconomic structural barriers. I just also want to sketch our picture in South Africa towards implementing Hep C interventions. So this has been a bit of a slow process since DAAs have been available. We've seen harm reduction services being scaled up in the country from 2016, predominantly through civil society. And we've had our national guidelines for hepatitis updated in 2019, with DAA formulations being registered in 2021 and a year later being launched on the market. So traditionally, we would treat hepatitis C at specialized hospital clinics, and patients would then have to attend multiple visits before treatment is initiated. But following a surveillance study we conducted at our organization among the community of PWID accessing services from our facility, we identified individuals who required treatment but failed to be initiated at the specialized units. So we decided to pilot a community-based simplified test and treat approach. This was in collaboration with the University of Cape Town and Doctors Without Borders, by really making diagnostics and treatment available at primary care level. For our pilot, community-based recruitment from the PWID community really leveraged the existing harm reduction interventions, and especially peer educators at our drop-in facilities to then trace patients who is known with chronic Hep C infection. But we also offered Hep C antibody screening at community hotspots at that stage during COVID-19 pandemic lockdowns, also at temporary shelters, and then walk-in patients. And for those who screened positive, we had same-day collection of blood for a qualitative PCR assessment and of viremia on site. So participants who were confirmed viremic were then further assessed for eligibility and initiated on DAAs and followed up again within these community structures. So this uptake cycle really resulted in a snowball effect where participants presented to our facility for screening or treatment as a result of word-of-mouth referrals. To cater for the large portion of homeless beneficiaries Our drop-in facility also offered showers, lockers, meals, safe spaces to collect with peers, and other biopsychosocial interventions. So just a brief overview of our simplified model. So we led with the rapid diagnostic testing for Hep C, but then also HIV and Hep B surface antigen. And those who were found to be co-infected were first stabilized on antiretroviral therapy or tenofovir-based therapy. We also offered Hep B vaccination if they tested negative for surface antigen. And if found to be pregnant or tuberculosis were diagnosed, DAA therapy would be deferred. So we then, after screening, conducted clinical assessments looking for signs of chronic liver disease, but especially for decompensation, and the decompensated clients would then be referred for further workup to the hospital level. Eligible participants who were found to be viremic were initiated on 12 weeks of phosphatidylclatizumab, and we also supported adherence with directly observed therapy. So this was really individualized, how frequently we would see the client, or it would be synchronized with other harm reduction services. Also peer support running throughout, stipends being given, or transport support depending on the individual's need. So in a high-risk setting like ours, it's really ideal to have the rapid diagnostics available. We made use of the OraSure technology, the antibody testing, which can also be used for self-testing. But interestingly, in our participants, the majority requested assisted testing by either the community health worker or peer educator. And we thought this was largely due to a large portion being first-time hepatitis C testers. So to give you a better overview of the demographics of our cohort, so of the 144 who were positive, who were assessed by the clinical team and had bloods done, 91% of those who had assessments were confirmed viremic. The majority were male, and with a mean age of 36, and 90% didn't know the hepatitis C or HIV statuses of their partners, whether injecting or sexual. The majority were also unsheltered or sheltered homeless. And then when looking at this Hep C cohort disease breakdown in terms of co-infection, we found 40% to have HIV co-infection, 4% Hep B co-infected, and 1% triple infected. So in our case, we used point-of-care molecular testing, a qualitative assay, which was the gene drive, to monitor our patient outcomes. We did it at 4 weeks end of treatment and 12 weeks post end of treatment. And I must say the point-of-care technology was really a game changer for us, where it enabled same-day or close to same-day initiations due to the results being available, and thus reducing the number of missed opportunities and also minimizing the difficulty of tracing a very transient population. So we also confirmed our SVR samples against a central laboratory, the Abbott real-time HCV, for the SVR confirmations. And we found the gene drive to have a high specificity and negative predictive value. So a significant practical issue that influenced our sample workflow was actually difficult venisections. And we had to make use of a dilution protocol to improve the performance of our assay with low volume or often hemolyzed samples. More recently, we've been using the GeneXpert quantitative PCR system on site, and particularly also the Hep C viral load finger stick, which only requires 100 microliters of EDTA whole blood, and using the mini vet as a collector for that. To highlight how this really enables quicker turnaround times, our viral load assessments were done within a mean of 7.4 hours, and this would be on days where there's high volume screenings happening, or co-infections also being present. And initiations would often be offered within a week, sometimes even within an hour, really just depending on the patient's follow-up plan in terms of their other harm reduction services, for example, weekly dotting of their methadone. So just to share some outcomes, final outcomes of our simplified treatment pilot for Hep C. So those eligible to be initiated, 92% commenced on soft DAC, and we achieved a per protocol SVR of 90%, noting that there was about 13% confirmed reinfections post SVR, but very few adverse events being reported, and all of them mild. Just want to share a quick word on reinfections. So in our setting, those who were suspected to have reinfections had the Hep C virus sequencing confirm it, so no resistant associated substitutions were observed. But in response, we really have to think about annual screening being offered, also knowing that retreatment is acceptable if patients are found to be reinfected. And then really optimizing harm reduction, which is not at scale at present, to be offered to reduce exposure to new Hep C infections. In our case, the majority of participants were either on OST or NSP, and we didn't find any statistical significantly different outcome, whether they are on one or the other, in terms of SVR, which was also encouraging for us. The key findings from our project revealed that the simplified point of service Hep C care model really yields acceptable SVR rates in our setting, but retention in care and follow-up remains both challenging and key to success. Our model also provides a basis for other programs in the region to utilize more community acceptable and cost-efficient approaches. And our successful implementation was really achieved through tailoring to the needs of our community and strategic collaborations. So I would just like to thank some of our collaborators, in particular MSF, the University of Cape Town, and then all the implementing partners supporting harm reduction services. Just to disclose. Thank you.